What I'm going to talk about is surgical planning. Obviously, what our patients want is superb results. I mean, the bar is getting higher and higher. And just recently, I had a patient in whom I did cataract surgery. As she is being wheeled out of our ASC, she says, my vision's a little blurred. You know, that's how quickly they want to see. Our patients, right? So there's very little room for error. And if we want to address astigmatism, which can very readily be done by practically every practicing ophthalmologist who does cataract surgery, we need to know and understand about astigmatism, what it means, how to diagnose it, and how to surgically plan for it. These are my financial disclosures. So what I do, and I'm going to talk about kind of what I do. It doesn't mean it's right or wrong, but every single person who has astigmatism between 0.50 and about 1.25 to 1.5 diopters, I try to correct with an LRI because we don't have low cylinder correcting toric IOLs in this country. They do exist in Europe. If the cylinder is higher than that, then I offer them a toric implant, whether it's a monofocal toric or a true line toric. I have noticed, and there's a lot of data that shows cylinder over 0.5 degrades vision. And obviously, we're trying to get patients to see without spectacles. I never say that to my patients. I always say you'll be relying on your glasses less often or less frequently. So what are the advantages and disadvantages of torics versus LRI? So I tried to put a little grid together. I'm sure all of you will come up with even more reasons. But the advantages of torics are they're certainly more reliable. You have less of an impact on the cornea because you're not putting those additional cuts on the cornea, meaning that those corneal nerves may be cut, the patients may have exacerbation of their dry eye, and so forth. The advantages of the LRI, on the other hand, are that they're easy to perform. Most ophthalmologists can master it very, very readily, and they are more cost-effective than toric IOLs. The disadvantages of the torics are, just as I mentioned, we don't have the low toric IOLs in the U.S. There are some rotational issues with some even perfectly placed toric IOLs. For a variety of reasons, they do rotate. And preoperative marking is key. We still haven't perfected that yet. There are issues with preoperative marking. We want it to be as close to where we want to put it. And obviously, the position is critical. You want that implant to be and seat exactly where you want it to stay. And of course, they're more expensive. The LRI disadvantages are that they're very unpredictable at times. It depends on how quickly or slowly a patient heals. And there is kind of surgeon variability, and you are exacerbating potentially ocular surface disease. So this is a case study. One of my patients, she's a 68-year-old woman who was a rather high myope with astigmatism. And she used to wear toric contact lenses, soft contacts. She had some dry eye issues being postmenopausal, and she was no longer comfortable with her contacts. She had visually significant cataracts, so we decided we'll go ahead, do cataract surgery, and replace her toric contacts with toric implants. Made sense, right? So I'm going to go through with you, this is how I approach my patients in calculating the implants. So I looked at the IOL master, just like many of the speakers have said and Mark, I look for consistency in my K readings between different equipment because I want a reaffirmation that what I have is reliable data. So these were her Ks. Then I looked at my OPD3, and her Ks were very consistent with the IOL master, so it's giving me confidence that, yes, these are good numbers. And then finally, I looked at my flat and steep Ks from the Cassini, and they also match. So I said, great, I have 4 pieces of equipment now. We use manual keratometry as well. That's calibrated on a daily basis. And only 2 of my most senior techs are allowed to do my preoperative manual case. So everything was looking good. Everything was very similar. I said, okay, let's see what the pattern looks like. So it's not just the magnitude and the axis. You have to also look at the pattern of the astigmatism. So looking inside the circle, her pupil diameter, she had a good bow tie pattern. So I said, okay, you're a good candidate for a toric. I plugged her into an Alcantara calculator, and it showed that she would benefit from a T3, and there would be just a little bit of residual sill with the rule, and I was happy with that. But she wanted accommodative, a true line implant, because she wanted to see distance and middle. So I said, okay, we can certainly do a true line for you. And I plugged it in, and it told me that to use a true line of 2 diopters. I plugged it into my holiday calculator, and it reaffirmed and confirmed that my true line 200 would be the ideal choice. Then I looked at my Cassini total cornea, and for now, it did not agree with anything else that I was looking at. It told me that my total corneal astigmatism was 0.3 diopters with the rule. So that made me stop and think. That was my stop sign. I said, if I were to put in a true line in this patient, I'm probably going to overcorrect her, which will yield into a worse kind of situation than if I put in a non-toric implant. I can always do an LRI and always correct the cylinder if there's any left. So I called her up and I said, we're going to swap you out from a true line to a crystal lens. She agreed, and indeed that's what I did. I put in a crystal lens, and I did a single arcuate LRI on her. And thank God I did that, and thank God my Cassini told me and showed me the TCA so I could evaluate it better, because she was one of the outliers that we all see in our practice. And her result was wonderful, 20/20 plano. So in conclusion, I don't actually have access to an aura, unlike Dee and Jim. I don't have that. So I rely on my Cassini so much to help me find these outliers, because without my Cassini, I would not have been able to find this, and then this patient would have ended up with a true line and would have been overcorrected with her cell. We like our Cassini so much that we have 2, not 3 like Ivan, but we have 2, and we use it regularly. It's easy to use. The technicians have no issue learning how to do it, and I think with a newer module with less brightness of the light when you're capturing the data, it'll be even more comfortable for the patient. I've been most impressed with iOptics, the amount of research that goes into it, the upgrades that keep coming down the pipe. It's fantastic. So thank you to all that you're doing. Thank you very much.